Hello, my name is Jamie Reed. I am the Dean of the Lincoln Medical School and also an Associate Specialist in Geriatric Medicine. I guess I've had a bit of an interesting career path in the sense that I probably haven't taken the most typical route to become a clinical academic, and particularly into a kind of education research and leadership role. I guess things did start off reasonably as you would expect, in that I went to medical school and I trained at the Peninsula Medical School as one of the first graduates going through what at that stage was a brand new school. And because lots of the course was being created and developed as I was a student there, the team were always very good at explaining why they were teaching us in the way that we were, which really piqued my interest around medical education. So at the end of my 5 years at medical school, I decided that I fancied doing an academic foundation program. And at that stage, the application process was slightly different in that you had to apply out with the standard applications into the foundation program. And I was lucky enough to get one of those. And I spent my F2 year with a third of my time protected working in Torbay Hospital. And that gave me a brilliant opportunity to undertake some small scale education research and start to really understand more about what an education research and education career would be like. From that, I went into core training, moved back to Plymouth for that. And whilst I was a core trainee, learned more about the NIHR academic clinical fellowship route. And again, was successful at the point of applying for my higher specialist training in geriatric medicine to get a ACF. And that allowed me to put together a research proposal to think about completing my master's, but also to put together some funding proposals around PhDs. And at the point I managed to get some funding from within Plymouth University, I then took an out of program research job and did over initially full time and then part time my PhD in medical education. But the point at which I finished my out of program research, I decided that actually I really quite fancied moving into an education career earlier on. So made the very difficult decision at that stage to resign my training number and moved into a specialty doctor job. And that was actually a really good opportunity just in terms of something that allowed me to really focus on developing an education career portfolio. And I suppose the rest kind of is history, in that I took on increasing leadership roles, was able to balance that alongside some education research, and somehow I've ended up dean as a medical school, and really proud to be the first SAS doctor to hold that post. Now, a lot of what I do these days is about leadership and management, but I do still very much try and keep my research interests going alongside clinical practice, particularly looking at student support around assessment. So my research is very much around education, very much kind of pedagogic, qualitative researcher. And when I did my master's in medical education in Plymouth, I got really interested in the concept of assessment failure, and less in terms of what that meant academically for students, but very much what it meant in terms of how they perceive themselves as future doctors. And this got me very intrigued around this concept of professional identity development or professional identity formation. So as I moved into my ACF and thought very much about PhDs, I decided I wanted to undertake a project that explored what the impact of assessment failure was on students and their evolving professional identities as doctors. And I did that very much through questionnaires and interviews with a reasonably small number of participants, but quite then an in-depth qualitative analysis using what's called a narrative approach to understand what not just what students were saying, but some of the meaning behind the stories that they gave. And that's been really, really helpful, particularly as someone who's now leading a medical school, because what I learned from that was very much around how, although we might say things in the way that we design assessments about they shouldn't be competitive, it's about patient safety, it's about a learning approach. What many students take away from the way we assess them is that it is very competitive, that it feels very personal, and that for individuals who fail assessments, they take that really on board, which means that rather than a focus on improving their skills, actually it can really damage their sense of becoming future doctors. So I'm continuing looking at that, and particularly as we set up a brand new school with a new curriculum and a new assessment approach, that's been fantastic in terms of integrating that into what we do and how we're going to assess students in Lincoln. It's certainly a very varied role. And I guess no day is the same as any other. For me, I think having an education research or education leadership career as a clinical academic is a really nice way of balancing things and giving you essentially a portfolio career. So I'm still doing some clinical work 1 day a week, and that's great because I think that's really important in terms of retaining that credibility as someone who's got a senior education leadership role. But it also means when I go in to do my clinical work, I really, really appreciate it. And where I've moved jobs and I've had times where I haven't been doing clinical work, I've really missed it. And I think it really reminds me why I wanted to be a doctor in the first place. The rest of the week is then a huge variety of internal meetings looking at how we support students, how we develop curricula, supporting members of staff within their own professional development, but also a really nice opportunity then to do some external work as well and meet with, for example, colleagues in our integrated care boards, within our local NHS partner organisations, and of course within primary care and GP practices. So for me, it's a great opportunity to bring together lots of different groups to try and promote education and fundamentally, therefore, provide really excellent patient care. So I certainly don't have a boring job. It can be very challenging sometimes, particularly when discussing things like funding. But actually, the opportunity to make a huge difference, not just now, but in the future, is fantastic. Yeah, there are certainly quite a significant number of challenges that I'm sure are common with many individuals. And I guess the positives of a portfolio career is variety. Some of the disadvantages can be that, of course, things don't stop just because you're not working on them that day. And I think sometimes balancing those many requirements can be really difficult. I think in particular, maintaining skills, making sure that you're up to date, ensuring that there's still continuity of patient care and good handover when you're only working 1 day a week clinically, that can be really challenging. And I guess the other thing is, particularly from a research and clinical academia perspective, there's always a sense of needing to apply for the next set of funding, to go for the next grant, the pressures around publication, and sometimes it does feel like there aren't always enough hours in the day. My sense is that often joining established research groups or building communities of practice is a great way to do that, and sometimes feel a bit lonely being a clinical academic and a researcher. So the more you can build a team who can share that load with you and really support each other, the better. So I think there are lots of appeals around clinical academic careers, and I think particularly that variety is really, really important because things are busy, things are challenged, and sometimes that sort of old mantra that a change is as good as a rest can be true, although it's really important that it's not flat out all the time because, of course, that can lead to burnout. For me, one of the big advantages and one of the reasons when I speak to colleagues about why they've gone into clinical academic careers is that it gives you a different way to make a difference. So often when we're working as clinicians, we're focused on interventions, diagnostics, individual patients, and that's fantastic and really rewarding. One of the huge advantages around clinical academia is it allows you to take that learning, but often to a population level. So you can have huge impact on many, many individuals simultaneously. And I think that for many people is a huge opportunity for clinical academics to impact. The other thing, of course, is that it's also a great way to meet new people, to get out to travel, to have an opportunity to really expand your knowledge and challenge yourself. So there are definitely advantages around work-life balance, but also if you're really someone who's got that kind of hunger for knowledge, it's a great opportunity. I think widening access is really important, and certainly within Lincoln, it's one of the reasons that we're really keen about developing a new medical school here. Ultimately, my view is that the group of doctors that are treating patients need to be representative of the local population. And that means that we need to make sure that we're really opening up opportunities in healthcare, and particularly in medicine, to our entire population. And I think historically, there's been a real sense that actually you need to be getting 3A stars at A level or very high scores in Welsh Bac or International Baccalaureate. My sense is that the world is changing in terms of we've all got smartphones now. Goodness knows how AI is going to change things. And actually selecting more around what we've historically called non-technical skills is going to be really important. And I think that has a real opportunity for us to review what that means in terms of recruiting the best talent into medical schools. We know that sadly, depending on where you live, still makes a big difference to the opportunities that you have. And medical schools have a real role in making sure that we level the playing field and provide that equity of opportunity to all individuals who are interested in medicine if they've got those right attributes to do it. It's still very expensive to go to university, and that it is a big barrier for people from some backgrounds. But in particular, what we're focusing doing in Lincoln is thinking very much about, well, what we can do is try and get out into schools, particularly primary schools and secondary schools, to help people realize that actually careers as doctors are hugely rewarding and that anyone should consider doing it if it's something they want to do. And we can then look at the financial support, the role modeling, the work experience and things around it. So I definitely think there's more and more that we need to do. There are still challenges though. Certainly tuition fees, cost of living, all of those things remain big barriers for many individuals studying. So it's really important, I think, that as medical schools, we work together to manage that. And particularly with the amounts of debt that we know that foundation doctors are coming out of university with, and the fact that it takes a very, very long time for them to pay that back, there are still some fairly big barriers that I think we need to be lobbying on, particularly at a national level. I think being a good educator is something that aligns very much with lots of the skills that doctors have already. Being a good educator ultimately means caring about people. And I'm sure everyone who's watching this, everyone who's gone into careers in healthcare and medicine has done that because they care about people. And it's slightly different, I guess, as an educator because you're caring about your students and your learners, but ultimately that's done because you want them to deliver excellent patient care. So caring about people is really important. Being inquisitive, again, a bit like being a doctor, you want to know what makes people tick, how they learn, try and impart new knowledge. And I think also a sense of being able to explain complex concepts well. And again, it's something that we really select doctors for because explaining sometimes very complex disease processes to those who haven't got a healthcare or medical degree can be really difficult. So I personally think there's massive overlap. It sort of, I guess, also is for those who want to make a difference for a long time too, because the nice thing about being an educator is that when you teach someone, of course, what they'll do is go on and teach others. So you get almost this ripple effect where the one intervention of teaching you make can have a huge impact across a much larger cohort of individuals. But I guess ultimately, the reason that most people who become educators do so is because they enjoy it. And I think actually being an educator is really rewarding, can be challenging, but most importantly, people do it because they find it fun.